Good morning, everyone. I'm from San Antonio, and welcome to SOLTI Young Perspective. My name is Elia Segui. I'm a breast medical oncologist and translational research, originally from Barcelona, Hospital Clinic de Barcelona, but now a research fellow at Dana-Farber Cancer Institute. And I'll present you some updates on translational research. Specifically, I will talk to you about the PROT study that was presented just a couple of minutes ago in the general session 2. We all know that hormone receptor positive, HER2 negative breast cancer is the most common type of breast cancer. And despite we've seen a lot of advancements in chemotherapy and endocrine therapy, there's still a lot of room for improvement because we do see that patients still have early and late recurrences, especially in the node positive disease. We have recent really promising data showing that a subset of these patients may benefit with the addition of immunotherapy. And we also have preclinical data and actually clinical data in triple negative breast cancer that shows that the combination of radiation plus immune checkpoint blockade can improve anti-tumor immunity. In the PDRAT trial, they tested the combination, it's the first randomized trial that has tested the combination of radiation plus immune checkpoint blockade in hormone receptor positive, HER2 negative breast cancer. And the hypothesis of the authors was that the combination of radiation plus immune checkpoint blockade would increase T cell infiltration, anti-tumor immunity, and therefore improved outcomes. Now moving to the methods of the study, 51 patients were included. Patients were ER positive, ER had to be above 10%, PR positive that also had to be above 10%, node positive, and all patients were high risk, meaning grade 3, high genomic platform, or Ki-67 above 20%. And then patients were randomized 1 to either zero radiation, so no radiation, low radiation, which was 9 grays, or high radiation, which was 24 grays, in combination with immune checkpoint blockade. And then they had after 2 weeks biopsy. And then after the biopsy, patients proceeded with neoadjuvant chemotherapy in combination with immunotherapy, specifically paclitaxel plus pembro, sequenced by anthracyclines plus pembro, and then proceed to surgery and adjuvant treatment as a standard of care. And the primary endpoint was T cell infiltration compared at 2 weeks compared to baseline, and they measured using a multiplex immunofluorescence assay that tested cytokeratin, CD3, and CD8. And as secondary endpoints, they had PCR and PCR rate. And moving to the results of the study, and I think those are really interesting. We've seen that the T cell infiltration increase at 30% T cell infiltration increase in the no radiation arm, so just with immune checkpoint blockade, a 40% increase in the low radiation arm, and a 53% increase in the high radiation arm. And that's statistically significant if you compare it with a no radiation treatment arm. And I think what it's really, really interesting is that they've seen that in the high radiation arm, at the 2-week biopsy, they see an increase in tertiary lymphoid structures containing T cells, B cells, dendritic cells, and these structures have shown to have a really good prognostic role and also predictive role for immune checkpoint blockade in other solid tumors. It wasn't the primary endpoint of the study, but we've also seen really promising PCR results in this super high risk population. And further exploratory analysis have shown, as expected in my opinion, greater benefit in non-luminal A tumors and greater benefits in tumors that increase their PD-L1 expression at week 2. In conclusion, further studies evaluating the role of combining radiation with immune checkpoint blockade in hormone receptor positive HER2 negative breast cancer are warranted to see if we can expand the subset of patients that will benefit from immune checkpoint blockade. Thank you so much for your attention, and see you soon.